Thank you very much, Howard. And obviously, after this fireworks of data, I have to slow down. I actually come up with a few provisions of where we will be in 2030. These are my financial disclosures. And I think I would like to start with a few projections and maybe even expectations. So we will have improved disease awareness and access to TAVR, explosive growth of TAVR worldwide, accelerated innovation of TAVR platforms and evolving accessory devices, aortic valve remodeling technologies such as scoring and lithotripsy, redefining disease state and timing and trigger points for therapy, something that is very, very important as we move on, and of course, realization of new clinical extended indications. So if we look at functional classification and maybe even new trigger points, I think it is clear that we started early with severe aortic stenosis, that patients are symptomatic in the trials that we all know. And now we're moving on to severe AS, asymptomatic basically, and moderate aortic stenosis with symptoms. The two trials are coming up, and we will expecting those results. In the moderate aortic stenosis without symptoms, as well as mild aortic stenosis, I think we all agree are in active surveillance. My belief is that we will be treating all of those, including bicuspid, at some point in time with TAVR for the most part. Something that I would like to draw your attention to, which I believe is very, very important, improved patient selection and disease awareness. As we move along, we've learned a lot about when to intervene, if it's too early, if it's too late. The same basically with mitral valves. 30% of patients undergoing TAVR derive minimal symptom benefit or die within 1 year. So we have to really focus on patient selection in order to be even more successful. Who will we be treating in the future? Summarized here, and I will go through some of those. Asymptomatic moderate aortic stenosis, quite obvious. Why are we targeting asymptomatic and moderate aortic stenosis as we move along? This is why. Basically, if you look at the mortality in untreated aortic stenosis patients, then you see a huge discrepancy in all stages, except maybe for severe aortic stenosis. There's a discrepancy between patients that are treated and mortality. That's why we have to tackle those patients and come in earlier. Moderate aortic stenosis is as bad as severe aortic stenosis. Unfortunately, still watchful waiting is ingrained in clinical practice. Moderate AS is not a benign disease. Very important, and following up on the early diagnosis, the damage among moderate aortic stenosis as we move along, the higher the damage, or the larger the damage of the heart is, the higher the mortality. So we have to intervene earlier in order to avoid these changes. There are challenges in evaluating cardiac functions because we have to find out not only the time, but how do we define those early changes. We have echo, we have cardiac CT and cardiac MRI, and of course, biomarkers. The moderate aortic stenosis trials are summarized here: TAVR Unload, Progress, and Expand. And TAVR Unload, the enrollment is complete. We have presented either at a European Society meeting or at TCT 2024, though that will give us some insight into the early stages. My prediction number one, TAVR will be the treatment of choice for all patients with severe, asymptomatic, and severe and moderate aortic stenosis. Next step, aortic regurgitation. Guidelines for aortic regurgitations have not changed in decades. We wait for symptoms, wait for LV dysfunction, or wait for severe LV remodeling. Growing data suggest that the guidelines also recommend treatment that is too late. So there's a case for redefining what is moderate aortic regurgitation as much as for aortic stenosis. The case for redefining moderate aortic regurgitation, significant AR is not uncommon, but terribly underdiagnosed. 2D echo is inadequate for quantification of AR severity and of LV remodeling. Forget linear dimensions, beware guidelines are outdated. Despite patients having a long asymptomatic clinical course, the LV is feeling it. Don't stop at moderate AR, use CMR to confirm. While the current goal is to address the immediate need for HR inoperable patients, true success will be measured by transformation of the diagnosis, selection, and treatment of aortic regurgitation patients. Here you see the poor agreement between echo and cardiac MRI severity, something that's very important. Don't rely, when it comes to diagnosing, don't just rely on echo. We have seen this before the ALIGN-AR trial. Given those excellent results with the Jenner valve and maybe even with the upcoming J valve, my prediction number 2, aortic regurgitation grading will be redefined. Patients will be treated earlier and more effectively via transcatheter approach with dedicated devices. Finally, bicuspid aortic stenosis, a lot to think about. Anatomical consideration, bicuspid valve has a lot of impact in the surrounding structures. Treatment choice, you can see there's a trend to doing more TAVRs. And if you look at in-hospital outcomes, TAVR is doing quite well compared to surgery. Future progression and aortopathy we have to take into consideration. We know which is good and which is not so good for TAVR. The more calcium we have, the more calcified raphes we have, the worse are the outcomes. We do have in aortic valve disease, we know what we know, some warnings and obviously some remaining questions. The most important one, there is, I believe, need for randomized trial of TAVR versus surgery and larger cohorts with long-term follow-up in patients with bicuspid valve disease. One of those studies is underway, Switzerland Navigate Bicuspid Trial, randomizing TAVR versus surgery. Prediction number 3, bicuspid aortic valve is an anatomical factor that favors surgery. However, patients will continue to be treated with TAVR given the excellent results so far, after considering specific risks and preferences in a joint decision-making process until the results of randomized controlled trials come out. Finally, small annulus. Howard was kind enough to provide me with some of these slides. Small annulus patients are not uncommon. You can see here 22 to 44% and surgical prosthesis less than 21 millimeter bad, really bad. Use of small TAVR prosthesis in the randomized trials, the percentage is significant, higher in Southern Europe and Asia, TAF and TAF 70 to 80%, and several-fold higher in women who make up to around 90% of small annulus population. SMART trial, the update he gave me, it's fully enrolled and submitted for late breaker at ACC 2022. Given the VIVA trial results, however, findings suggest in this trial that the two therapies, surgery, TAVR, represent a valid alternative for treating patients with aortic stenosis and small annuli. Treatment selection should likely be individualized. I think that's a fair statement. Prediction number 4, pending results of the SMART trial and based on the results of the VIVA trial, TAVR represents a safe and effective alternative to surgery after careful consideration of patients' age, preferences, and anatomical conditions. Finally, valve-in-valve, something very important, and this is an interesting slide that Philip was kind enough to provide with me. Here you can see valve-in-valve TVT 2023 followed by prediction, TAF and SAV, and TAF and TAF, and total valve-in-valve. So we will see more valve-in-valve procedures as we move along. Respectively, you can see 2023 and 2035, 6 times increase in those procedures. Longest follow-up of landmark trials, Samin has already summarized that, 10 years, 5 years, 4 years, and 1 year. More to come with fairly good outcome. At least there's no sign of bad things happening in TAVR valves. Obviously, valve-in-valve decision thinking, we have to consider patients, patient selection criteria, very important, pre-procedural planning, and of course, do the right procedure. Time doesn't allow to go into this. Lifetime management of aortic disease, concept number 1, first intervention, surgery. We see redual surgery or TAVR and SAVR, thumbs up, thumbs down. I learned this from Samin with his thumbs up and thumbs down thing. This is very good. Mortality data obviously speak for TAVR and SAVR. If we take first intervention, TAVR, and we look at the TAVR explant data, look at the mortality, thumbs down versus TAVR and TAVR, thumbs up, better mortality. The first cut is the deepest. TAVR will likely be the most frequent second intervention in a lifetime management of a patient. Then concept number 2. First intervention versus second intervention. We have basically the two representative balloon expandable valves and self-expanding valves. Durability questions obviously are there. Second intervention, we have to consider 8%, 10% if we look at balloon expandable, and in the self-expanding, those numbers are a little bit higher. First TAVR choice matters. TAVR repeatability might be as important than leaflet durability. What is important in Voodoo TAVR? Neoskirt, leaflet overhang, index THV expansion, and of course, leaflet modification methods, basilica and leaflet splitting, maybe even for bicuspid disease. Prediction number 5, and my last one, valve and leaflet modification procedures will increase. Which is the first procedure? Not all THVs and HHVs are created equal. Coronary access, fracturability, neoskirt, index expansion, and leaflet overhang. Second procedure, most likely THV. However, consider THV type, size, and positioning when you do a decision. And my last slide here, long-term management of TAVR patients will eventually improve with the ability to monitor patients from home with minimal disruption to their daily lives. This technology, along with improved home care pathways, will allow a greater number of patients to discharge to home. With that, I would like to close. Thank you, Shamin, again, and Gilbert for the invitation.
Thank you, Eberhard. We're going to keep moving along and save the panel discussion to the end. So I invite Raj Makar from Cedars-Sinai, one of the most prolific TAVR operators in the world, who has advanced our knowledge in so many areas, who's going to enlighten us today on TAVR for pure aortic regurgitation.
Thank you, Howie, and the first two talks were terrific.